Okay, good morning, good afternoon, and good evening to everyone, wherever you are in the world. Welcome to the ISGYP Live Western Hemisphere Journal Club. Our theme today is sex cord stromal and germ cell tumors of the ovary. I'm Becca Wolsky, speaking to you from the University of Colorado in the US, and joined by co-moderator Dr. Ian Hagemann, also in the US. Please feel free to say hello and let us know where you are in the world in the chat. We love seeing that. Before we get to our programming, I'll draw your attention to the upcoming ISGYP Live events. On January 24th, Rabina Wadi and Andre Pinto will be moderating the interesting case presentations by trainees and early career pathologists. And also on January 24th at noon Eastern time in the US, the ISGYP Live podcast will drop. That's with guest speaker, Dr. Zara Ordulu, and she's going to be speaking about the updates in sex cord stromal tumors. She's a very engaging speaker. I encourage you to tune in, and that's hosted by Jacqueline Watkins and David Chapel. So register for all of these events. You don't have to be a member of ISGYP, as I'm sure you're aware. A reminder that the ISGYP Journal Club is global, with the Western Hemisphere occurring the third Wednesday of every other month at 12 noon Eastern Time, and the Eastern Hemisphere occurring the third Thursday of the alternating months at 12 p.m. Melbourne time. Here's the schedule of topics through 2024. In February, the Eastern Hemisphere Journal Club's theme will be cervical pathology. So we really do encourage any trainee or early career pathologist with an interest in gynecologic pathology to volunteer to present at Journal Club or interesting case presentation. You don't need to be a member of ISGYP, and we do offer detailed mentorship leading up to these presentations. So if you're at all interested or know someone who's interested, please have them reach out to one of us via the emails listed here. So now to the main event. Our three volunteer presenters today are Dr. Saba Asif, a PGY3 at RWJ Cooperman Barnabas in the US. Next, we'll hear from Dr. Raji Balagopal, a fifth-year trainee joining us from the Royal Devon University Hospital in the UK. And finally, Dr. Farah Baban is the GynPath Fellow at Mayo Clinic at Rochester in the US. I'll ask each presenter to introduce their own article that they're presenting as we go through. The objectives for the Journal Club include engaging trainees and early career pathologists, offering opportunities for presenting and moderating to members from all parts of the globe, providing mentorship, and engaging future leaders like you from around the world. Here's the outline and assignment for our three presenters. And as a reminder, we're in a webinar format, so please use the dedicated question and answer or Q&A for questions to the presenters with the option to upvote questions. Use the chat, as I said, to say hello to everyone and let us know where you are. And here's our schedule for today. We'll hear from Dr. Asif first, followed by Dr. Balagopal, and finally Dr. Baban. Now I'll stop sharing my screen, and Dr. Asif, if you can then share your screen. And I'll ask other panelists to ensure that they're muted. You can feel free to turn your cameras off as well.
Hello, everyone. My name is Dr. Saba Asif, and I'm a PGY3 at Cooperman Barnabas Medical Center, as Dr. Wolsky has already introduced. So I hope you can see my screen clearly. All right, so let's start with our presentation. So the paper which I'm going to present today is titled Sertoli-Leydig Cell Tumor, Clinicopathological Analysis in a Comprehensive National Cohort. And this paper was published October last year in the International Journal of Gynecological Cancer. Okay. So as a brief introduction, Sertoli-Leydig cell tumors are one of the rare ovarian neoplasms, accounting less than 0.5% of all the ovarian tumors. Age range is very broad. They can occur in all age groups, commonly in younger women. And how they clinically manifest depends upon their hormonal effects. In younger women, it is more androgenic effects. And in postmenopausal women, it is more of the estrogenic endometrial hyperplasia, dysfunctional uterine bleeding, more of those symptoms. And WHO has given us histological grading based on their morphological, histological appearance. They can be well differentiated, where we can clearly see each and individual structures, moderately differentiated, poorly differentiated. Then there is a retiform variant. I'll quickly show a picture of that. This is one of the variant which is less studied in most of the studies which have been done. And then there are heterologous elements also, which are also considered in this study particularly. Then we'll move on to role of pathogenic variant of DICER1 gene in the development of these tumors, both germline and somatic. So here, the very first picture on the left-hand side, here I am showing the well-differentiated component. So by definition, as WHO has recommended, Sertoli-Leydig cell tumors should have varying proportion of both the components. Here we can see very well-formed tubules, which are lined by Sertoli cells, and then there are clusters of leading cells. And this is the well-differentiated, and here we can quickly compare with the intermediate, where it's all fibri-forming and it's making cord-like structures, and that is intermediate differentiation. And then we move on to poorly differentiated, where it is more or less giving a sarcomatoid appearance. This is the retiform structure, where it's giving a papillary or micropapillary architecture. And then this picture is showing heterologous elements, which can be glands. It can be any other structure, even rhabdoid. So any of these heterologous elements can be present in Sertoli-Leydig cell tumor. Now coming back to this paper, the method which they used, so it was a retrospective national registry-based cohort study that analyzed both the thing that shows in the title, the clinicopathological characteristics and the frequency of DICER1 pathogenic variant. And it was collected from Danish National Pathology Registry, dating back from January 1997 to December 2017. And then these charts were reviewed by 2 different reviewers so that they can compensate any biasing issues. And then the factors which they studied, the clinical manifestation, as I already mentioned, that how patient presented clinically, whether it were hormonal manifestation, non-hormonal, or incidental finding. Then they studied different treatment modalities, whether the patient was given neoadjuvant chemotherapy along with the surgery, or the patient was offered fertility-sparing surgery based on their wishes and the staging. And all these tumors, they were staged according to FIGO stage. And then all the patients who were alive by the time, they were followed up till April 2023, like few months before the publication. So overall, 41 cases were studied. And then cancer-related survival was calculated using Kaplan-Meier curve. And a p-value of less than 0.05 is considered statistically significant. Now, this is a very long table, and I think it's the crux of all the study, but we'll go one by one in the various factors. So very first thing which I want to mention is the age. So most of the patients, they were middle age, we can say 41 years, not very young, not very old. And then the next FIGO stage was, for most of the patients, which is 85% of the patients, they were at stage 1, and there were few cases which were at the later stages. Based on differentiation, again, we saw that most, which is 56%, more than half of the cases were moderately differentiated. Very few were poorly differentiated. second maximum was well differentiated. Now this is about the treatment modalities. So here we saw that 44%, which is again maximum number, they were offered unilateral salpingo oophorectomy, which is very not very debulking type of procedure. It's very well focused type of procedure. And then we saw that majority, which is 90% of the patients, did not receive neoadjuvant chemotherapy. Only 10% of the patients, just because that they needed, they really needed that chemotherapy. And the last option on this table, I want to highlight, this is very interesting, that even after getting treatment for Sertoli-Leydig, still there were few patients whose fertility was preserved and they could deliver after that. So this is very encouraging aspect. Now, this is another table, and this is just giving us an indication that what was the grossly appearance of those tumors and what was the size range. So here we can say that majority, which is 37%, they showed both solid and cystic component grossly. And then tumor size is highly variable. We can see many tumors which were less than 5, and then there is another option of more than 10 centimeters. So it's a highly variable, and we can see the percentages of those tumors is very high. So regarding size, we can just say that they were highly variable. Now, this table highlights the immunohistochemical staining pattern, which for majority of the tumors, it followed the typical IHC staining pattern, which other Sertoli-Leydig cell tumor shows. But there were very few exceptions for that. Like here, we can see that there were 3 cases which were inhibin negative. And similarly, there were 2 cases which were WT1 negative. So there were few cases which showed a little bit atypical pattern, but majority followed the typical pattern. Now, this is very important regarding the study, because here we can see cancer-related survival. Now, I would first follow the table on the left-hand side, and just quickly going through the key solid line here. This is showing the well-differentiated cancers. Then a small dotted line, this one underneath, this is showing moderately differentiated. And then these long bars, this line is showing poorly differentiated. So here we can clearly see that for the poorly differentiated, 5-year survival is almost 0. It's very less. And on the other hand, well and moderately differentiated, they have 100%, almost 100% survival rates. And similarly, going towards the table on the right-hand side, which is actually studying the staging with the survival. Again, the solid line is giving stage 1 and 2, and this dotted line is higher stages 3 and 4. Here again, we can see the drastic difference that stage 1 and 2 are almost 100% survival rate, but it is almost negligible for stage 3 and 4. So these 2 graphs, they are showing us how the differentiation and the early staging has a good prognostic indication. Now coming to the second half of the study, which is frequency of Dicer-1 among cohort. Now, one thing is worth mentioning that only 8 of those 41 patients were tested for Dicer-1 gene. One of the reasons which I imagined, because Dicer-1 testing was done, it was started later around 2011. So for those patients who were tested earlier than that, they might not have been offered. So this is the data only for 8 patients. Out of those 8, 50% had germline pathogenic variant of Dicer-1, And they all of them, somewhere in the past, they had a medical history within Dicer-1 syndrome spectrum. So they had multinodular goiter in 3 of those 4 and cystic nephroma in 1 of the patients. And this is all about germline. There was no somatic testing that was performed on those patients. Now here again, this is taken from that graph. I would say that staging is the best prognostic indicator, where early stage had better outcome and advanced stage had poor outcome. Okay. Oh, sorry. And then half of the patients, they were tested for Dicer-1 gene and they had pathogenic variant. So again, the same thing, that genetic testing was introduced in 2011. Now, this study suggested feasibility of fertility sparing surgery in young patients with early stage, regardless of histological grading. And then there is a point about surgery. So debulking surgery as well as adjuvant chemotherapy was done only for advanced stages. Now, why this is important? Because in previous case series, previous studies which we have read, there this debulking surgery and adjuvant chemotherapy, they were given for all the moderately and poorly differentiated patients, regardless of their stage. But this is changed now. This practice is now done only for advanced staging. And then there were previous Asian studies. They showed predominant, moderate, and poor differentiation. So this is a worth mentioning point. While other international studies, including US-based, they showed more well or moderate differentiation as a predominant grading. So one might think that there might be a difference in the population, or they might be caught at a different stages. So this is one of the point which I wanted to highlight. And then due to broad and severe phenotypes of Dicer-1 syndrome, identifying germline pathogenic variant is desirable for the patients as well as for their close relatives. And then close surveillance is recommended, including thyroid, pulmonary, renal, or ovarian imaging. So those patients who are diagnosed with syndrome, Dicer-1 syndrome, those patients and their relatives should be closely monitored. Now coming to strength and weakness of the study, overall, it is a very good study because they studied the entire country and it represented entire cohort. But it is limited in one way, that it is a retrospective, completely relying on pathology reports and moderate size of cohort, which might not be a true reflection of entire world. When we study the entire world, some factors might vary. And then for future clinical implication and research, larger cohorts are desirable to determine the prognostic value of Sertoli-Leydig cell differentiation grading, and as well as their correlation with the Dicer-1 status and tumor differentiation. And the last point, which is again a connection to the earlier, that all the individuals with this tumor, they should be considered for genetic counseling as well. So that was all my presentation. Thank you so much. If you have any comments or any questions, so feel free.
That was fantastic. Thank you.
Thank you.
I think we don't have any questions in the Q&A. And we're at time. We're at 10:20. I mean 12:20 Eastern time. So I think we could go on to, if you want to stop sharing your screen, Dr. Asif.
Sure.
And Dr. Balagopal, you can share your screen and then we can have discussion at the end if time allows.
Thank you, Dr. Wolsky. I hope you can see my presentation.
We can.
Hi all. I'm Raji Balagopal, The paper today I am going to discuss is this. It is published in International Journal of Gynecological Pathology in 2022, written by Simon Rajendran and collaborators. The title of the article is Bronchus-like Structures in Ovarian Teratomas, Report of a Series of a Previously Unreported Phenomenon with Potential for Misdiagnosis. A little bit background about teratomas before we go into the paper. Teratomas are germ cell tumors containing various tissue types derived from more than one germ cell layers. There are two types of teratomas, mature teratomas and immature teratomas. Mature teratomas usually occur in women of reproductive age group. They are mostly cystic in structure, and in terms of tissue composition, ectodermal and mesodermal derivatives are more common in them than endodermal tissues. Their clinical behavior is mostly benign unless secondary somatic malignancies arise from them, which is very rare. Immature teratomas usually occur in the first 3 decades of life. They are characterized by the presence of immature tissue, the most common one being immature neuroepithelium, and they are malignant in their clinical behavior. Respiratory epithelium is a relatively common finding in teratomas. Pulmonary type adenocarcinomas, though rare, have been occasionally reported to arise from ovarian teratomas as a secondary somatic malignancy. In this paper, the authors describe an uncommon and previously unrecognized benign lesion. They called it Bronchus-like structure. The importance of this is that it can be mistaken for malignancy based on the histological features. The study design of this paper is that of a case series composed of 10 cases of ovarian teratomas containing this histological entity. The authors studied the clinical features, the pathological features, and immunohistochemical characteristics of this structure. And wherever possible, they followed up the patients to understand the prognosis and clinical behavior of this lesion. Methodology. The cases were selected from the pathology archives of the hospitals where the authors are affiliated to. Some of them were referral cases sent to them from other pathologists. Most cases had immunohistochemistry done at the time of primary reporting, but a few cases required additional immunohistochemistry at the time of manuscript. Follow-up patient information was obtained from electronic records or from referring pathologists. Now let's look at the results. The number of teratomas containing this entity was equally present in left side and right side. The age range of the patients was between 16 years and 56 years with a mean of 36 years. In terms of pathological features, all of them were unilateral. 7 of them were unifocal lesions, while 3 were multifocal. The size of the ovaries ranged between 15 and 260 millimeters. The lesions were quite small in size, ranging between 2.5 and 10 millimeters. 8 were mature cystic teratomas. 1 was a mature solid teratoma, and 1 of them was an immature teratoma with abundant immature neuroepithelium, which made it a grade 3 immature teratoma. 1 of the mature cystic teratoma contained somatic malignancy. It was an intestinal type signet ring cell mucinous adenocarcinoma, and the same case contained this Bronchus-like structure, which was originally diagnosed as a pulmonary type adenocarcinoma. The follow-up information was available in 4 out of the 10 cases over a period of 18 to 130 months. None of them showed recurrence. 1 patient died from an unrelated malignancy. It was a renal cell carcinoma. This is a table showing a summary of the results, and the follow-up information is highlighted. As we can see, 3 cases were recent for follow-up, and 2 patients did not have any follow-up information available. Here are the microscopic photos of this entity. Picture A shows all the 3 components that are constantly present in this entity. The first one is this dilated cavity, which is eccentrically placed here. It is lined by respiratory type ciliated epithelium. And adjacent to that, there is the second component, which is a proliferation of glandular structures. The third component is the stroma present in between these glands. There was no mass lesion visible. Here, a closer look of the same area shows respiratory type epithelium lining this cavity. There is no cytological atypia. The glandular structures are lined by non-ciliated epithelium. C shows the stroma in detail, and we can see there is smooth muscle present in the stroma. The presence of smooth muscle was constant in all cases, but the amount of smooth muscle varied. Some cases had very little smooth muscle, while others had abundant bundles of smooth muscle. D is an area of the glandular proliferation, which shows the lining cells containing abundant foamy cytoplasm. This was also a feature that was present in almost all cases. More microscopic photos. This is another photo showing the Bronchus-like cavity, the proliferation of glandular structures, and the stroma in between the glands. Here, the glands are in continuity with the Bronchus-like cavity. This is another area where the glands are lined by cells having foamy cytoplasm. C was one case where the glands were lined by ciliated epithelium. All the other 9 cases did not have ciliated epithelial lining. D shows TTF1 immunostaining, which is strongly and diffusely expressed by both the glandular component as well as the cavity. E and F are napsin A immunostaining, which is also positive in both components. This is a low power view showing the architecture of the glands. Here, the glands are showing a lobular architecture with some stroma in between the lobules. This is a closer look showing the lobulation of the glands and the presence of smooth muscle in the stroma in between the lobules. A high power view shows that there is no cytological atypia in the cells lining the glands. D is napsin A immunostaining. So this is a summary of the morphological features. All cases had central or eccentrically placed, well-formed, dilated, Bronchus-like cavity. It was lined by respiratory type ciliated epithelium. There was no cartilage present, and there was no cytological atypia. A small number of cases contained some submucosal glands, which often showed squamous metaplasia. Adjacent to this Bronchus-like cavity, there was proliferation of glands in the surrounding stroma. This was often in continuity with the bronchus. Most of the glands had non-ciliated epithelial lining, except in one case where the lining was ciliated. At least a proportion of the glands had abundant foamy cytoplasm in 9 out of 10 cases. On low power examination, some had infiltrative appearance to the glands, mimicking malignancy, while others had lobular arrangement. The stroma in between the glands contained variable amount of smooth muscle. On immunohistochemistry, both the bronchial epithelium and the glands stained strongly and diffusely with lung markers such as CK7, TTF1, and napsin A in all the cases. The authors attempted prostatic marker NKX 3.1 in 4 of the cases, and 2 of them showed focal positivity, but this was in the submucosal glands, which was often associated with squamous metaplasia. These are the differential diagnoses that are considered in the paper. The first one is possibility of a fetal lung. Fetal lung during the pseudoglandular stage can have both glandular and stromal elements, which can look like this. But what goes against this diagnosis is the absence of tall columnar cells lining the airways and the absence of capillary network in the smooth muscle stroma. This is a diagram taken from the article used as reference showing the structure of fetal lung. Here we can see that tall columnar cells line the airway, and there is a striking vascularity in the mesenchymal component. Both these features are absent in these cases, ruling out the possibility of a fetal lung. The second differential diagnosis is ectopic prostatic tissue. NKX 3.1, a prostatic marker, was focally positive in 2 out of the 4 cases, but NKX 3.1 is not specific enough, and it is known that NKX 3.1 is expressed by mucinous salivary glands and bronchial glands. Moreover, other prostatic markers like PAP and PSA, when attempted, were negative in these cases. The third and probably the most important differential diagnosis is pulmonary type adenocarcinoma arising from teratoma. One of these cases was initially reported and published as this. So this is clearly an area of diagnostic confusion. It is the infiltrative architecture of the glands and positivity for lung markers such as TTF1 and napsine that can cause confusion with a malignant pulmonary type adenocarcinoma. But the features that can help us are absence of mass lesion, absence of cytological atypia, absence of mitosis, absence of desmoplastic reaction, and the presence of smooth muscle in the intervening stroma. Showing an infiltrative appearance here, mimicking malignancy. But on retrospect, the authors feel that this case looks just like the other 9 cases and are convinced that this is a benign Bronchus-like structure. Coming to the strengths and limitations of this paper, in my opinion, the strengths of this paper are the clarity in describing the clinical and pathological features. The authors have considered several potential differential diagnoses and systematically ruled out each of them. The paper identifies the pathological features that can cause confusion with a malignant entity and then very helpfully describes the features that can help in resolving the confusion. The limitations are the number of study cases are small, and the authors feel that this entity may be present more commonly, but because it is recognized as a benign structure, the reporting pathologists may not work up or comment on them. So the prevalence may be much higher. The follow-up information was available only in a proportion of cases because some cases were too recent or the records were not available. Finally, the applications and take-home points from this paper are: this paper describes a previously undescribed benign lesion with a relatively constant morphology and immunoprofile. And most importantly, this entity has a propensity for misdiagnosis as a malignancy. Thank you.
Great, thank you so much. That was excellent.
Thank you.
Do we have any questions right now? Not for now. I think we discussed offhand in our practice session. I thought perhaps they should call them bronchiole-like instead of bronchus-like, but
yes. So I think one of the features of bronchus versus bronchioles is, as we said, the presence of cartilage in bronchus versus absence of cartilage in the bronchioles. But I read that the other feature is presence of glands adjacent to this bronchial cavity, which is a feature of bronchi and not a feature of bronchioles. So I think that's why the authors decided to call this bronchus-like structure.
Yeah, great, that makes sense. Okay, I think we can move on to Dr. Baban. You want to share your screen?
Yes, I will share my screen. I hope you see it in presentation mode.
Yep.
Perfect.
Presentation mode. Great.
Good day, everyone. So my name is Farah Baban. I'm currently the Gynecologic Pathology Fellow at Mayo Clinic, Rochester, Minnesota. And I will be presenting a case report by Dr. Parra-Herran from the Brigham and Women's Hospital. It was published in the International Journal of Gynecological Pathology in 2022, July. So the case report is titled Endometrioid Tubal Intraepithelial Neoplasia and Bilateral Ovarian Microcystic Stromal Tumors harboring APC mutations. Before I go into the details of the case report, I wanted to shed some light on what makes a good case report for publication. Case reports are important, integral, and accepted part of the medical literature. Case reports date back all the way to the time of Hippocrates, and arguably even longer than that, to the time of papyrus records of ancient Egyptian medicine. Good case reporting demands a clear focus to make explicit to the audience why a particular observation is important in the context of existing knowledge. There are several guidelines available to help authors construct a good case report, such as the CARE guidelines, which have been developed by a number of international experts to help authors reduce risk of bias, increase transparency, and provide early signals of what works for which patients and under which circumstances. On the right side, I have included some of the items that are listed in their checklist, in my opinion, that are very integral for each successful case report, starting with a clear and short title, followed by an abstract or what we call a summary. That also needs to be short and concise, with avoiding abbreviations and references in this section, followed by an introduction or background, which explains the background of the disorder, and usual presentation and progression, and then followed with a detailed case presentation that describes the patient's relevant demographic information, any relevant medical history, symptoms and signs, any tests, any treatments or intervention. Then after that, a discussion where it provides additional relevant information not included in the case presentation, also evaluate the patient case for uniqueness and compare with the published literature. And finally, a good conclusion where it states clearly the main conclusions of the case report, give a clear explanation of their importance and relevance and possibly implications. So, microcystic ovarian stromal tumor, I'm going to call it from now on as MST, is a neoplasm of stromal derivation that's characterized by CTNNB1 or APC alterations. These tumors have been described to be unilateral and have an indolent clinical behavior. The newly described entity, endometrioid tubal intraepithelial neoplasia, I'm going to call from now on as ETIN, is a glandular epithelial proliferation within the fallopian tubes that are characterized by nuclear beta-catenin staining, and they are distinct from high-grade serous precursors in the fallopian tube. This report is about a case of bilateral MST and multiple left tubal ETINs discovered incidentally in a 41-year-old woman with previous history of colon cancer. So the patient was presenting with chronic abdominal pain and dyspareunia. Her past medical history was significant for endometrial ablation and colon cancer 7 years prior to her current presentation. She was treated with colectomy and radiation therapy. Because of her chronic abdominal pain and dyspareunia, she underwent total hysterectomy and bilateral salpingo-oophorectomy. On the gross examination, the left ovary contained a 9 mm well-defined solid nodule. The contralateral ovary and fallopian tubes, however, were grossly unremarkable. Figure 1 here depicts the microscopic examination of the left ovarian lesion. As you can see from A and B, we have the H&E sections, which was showing a diffuse growth of round cells with pale cytoplasm, round uniform nuclei. The cells were arranged in sheets and trabeculae that were separated by fibrous septa, hyalinized fibrous septa. Important to note that the intracytoplasmic vacuoles and the coalescing spaces in between the cells that usually gives the microcystic characteristic pattern was absent in this tumor. Immunohistochemistry was done, and you can see beta-catenin is showing a both nuclear and cytoplasmic expression, and it was also showing a weak nuclear expression for SF1, strong nuclear expression for cyclin D1, and lastly, reticulin was showing, which is a special stain, was showing absence of the stain in the areas of cords and nests. The right ovary, although grossly was unremarkable, however, on the microscopic examination, they discovered an incidental nodule that was measuring 1 mm, as you can see in A here, with similar morphologic features as we saw in the contralateral ovary, and also a similar expression for reticulin here with loss of expression in the nests and cords of the tumor. The microscopic examination of the left fallopian tube, identified multiple, or around 4 foci of these subepithelial glandular proliferations that are crowded glands back to back that were lined by this non-mucinous stratified epithelium. And these foci were showing also nuclear and cytoplasmic expression of beta-catenin, and was also showing nuclear loss of nuclear stain of P10. And these features constitute what we call endometrioid tubal intraepithelial neoplasia, E10. They did a comprehensive next generation sequencing on the left ovarian MST and on the left E10. They used a oncopanel, which is an extensive molecular panel that looks at exonic regions of 447 cancer genes and intronic regions of almost 60 genes. The results showed 2 APC mutations in the left ovarian MST, including a deletion and insertion. And then the left E10 showed an APC mutation similar to what was seen in the left ovarian MST, in addition to another mutation, however, in a small percentage of reads. No copy number variation, structural alterations, or other pathogenic mutations were found. Based on these pathologic findings, genetic counseling and testing was recommended. However, the patient was lost for follow-up. So, as I said earlier, MST ovarian is an ovarian tumor of presumed to be of stromal derivation, given the nuclear staining for beta-catenin, FOXL2, WT1, and SF1. Also important to note, other markers that can be positive in these MSTs is CD10, vimentin, and cyclin D1. And typically, and most importantly, they are negative for inhibin and calretinin. As you can see, you can use these 2 markers to differentiate between other mimickers. These tumors are mostly indolent, except for 1 case that was reported to have a recurrence 9 years after the initial diagnosis into the contralateral ovary and iliac fossa. Most MST harbor missense point mutations in CTNNB1, whereas the remainder have APC gene inactivation. These mutations are usually mutually exclusive. And in the context of APC alteration, MST can be a manifestation of familial adenomatous polyposis. And then, given the finding of an APC alteration in this patient and her prior colon cancer, it is conceivable that this patient was an APC carrier and hence has the FAP syndrome. Another important entity to mention here is what is described as solid pseudopapillary tumor of the ovary. This neoplastic process has overlapping features with MST, both morphologically and in the immunoprofile, and most importantly, both have CTNNB1 mutations and do have nuclear beta-catenin expression. And this has led some to believe that these 2 entities are related and may represent a spectrum. However, it's yet to be found out if they have any distinct features to separate between morphologic features to separate between the 2 entities as distinct. The newly recognized or described E10 is a rare phenomena documented in less than 1% of fallopian tubes on microscopic examination in 1 academic institution. These are usually very small, less than 1 millimeter, and they mirror endometrioid neoplasia in their growth pattern. Important also to know that they're negative for WT1, have a wild type P53 expression, and have a low Ki67 proliferative index, usually less than 1%, which all these information are important to separate them from high-grade serous precursors in the fallopian tube. And then before we make an E10 diagnosis, it's important to consider the possibility of an endometrial or ovarian endometrioid carcinoma with the tubal spread. This is usually done through a careful clinical examination, and most important, examination of the endometrium and the ovaries for any neoplastic or preneoplastic processes. And in this case, they did an endometrial sampling that was negative for hyperplasia or carcinoma. Nuclear beta-catenin expression can be driven by several alterations. One of them is when we have an alteration in one beta-catenin signaling pathway, when we have a CTNNB1 mutation that leads to beta-catenin being resistant to degradation, and hence the accumulation of the beta-catenin in the nucleus, as well as APC alterations that may include inactivating mutations or 5q deletions, and this leads to a dysfunctional beta-catenin degradation complex, and again, accumulation of the beta-catenin in the nucleus. The underlying molecular mechanisms behind the development of scouts, which are the endometrioid secretory outgrowths that may lead to ETIN and eventually endometrioid carcinoma of the fallopian tube, is really unknown. Based on according to the authors, this report is the first to document APC mutations in the setting of nuclear beta-catenin staining in ETIN. And given the finding of an APC mutation, as I said earlier, and then finding and her prior history of colon cancer, she might be a carrier, a germline carrier, and hence has a FAP hereditary syndrome. So finding APC alterations in these lesions may alert to the possibility of a germline defect, and hence genetic counseling, germline testing would be important, and subsequent close surveillance to catch colon cancer specifically from developing. For summary and implications, MST can present with bilateral ovarian involvement. MST can be associated with ETIN, as both may be related to APC alterations, leading to aberrant beta-catenin expression. These neoplastic proliferations should be included in the spectrum of hereditary APC alterations, including FAP. Diagnosis has potential implications for the surveillance and diagnosis of other neoplasms related to defective WAND signaling pathway. And going back to the case report as an evaluation based on the care guidelines, I believe, in my opinion, it's a well-written case report, and that has satisfied all the checkboxes here for what's mandatory to be included in a successful case report. Other strengths of the case report was pathology findings that were detailed with an expanded panel of immunostains. There was an extensive panel of molecular study, and most importantly, in comparison between the two entities. In my opinion, weaknesses might be missing details regarding the prior malignancy or colon cancer. We did not have any idea of what side, was it involving? Was it the left colon or the right colon? What type of adenocarcinoma? Was there any intertumoral or peritumoral lymphocytes? These are indications to us suggesting is it an APC-associated mutation versus a Lynch syndrome, for instance, which also can occur in a young age. Also, unavailable patient follow-up with no patient germline testing. There was a strong association with the APC mutation. However, germline testing was not done and hence not confirmed. And that concludes my presentation, and I'm ready for questions.
Great, thank you so much. Okay, no questions right now in the Q&A. We'll wait a moment and see if somebody wants to join in. Yeah, if you want to turn your cameras back on. I want to thank all of our volunteer presenters, and we are looking for volunteers for future journal clubs and interesting case presentations. We can chat a little more, but I want to remind our audience, I want to thank you for joining us. And as you log off the Zoom, I believe you should have a survey pop up, and we really encourage you to fill that out. We follow those results carefully, so you can let us know what we're doing well, what we can improve on. Yeah, that last paper, I think that's an excellent example of an informative case report. And I want to add for people out there in the audience that I 100% agree with the diagnosis of the microcystic stromal tumors. The 9 millimeter and 1 millimeter is much smaller than the typical example of a microcystic stromal tumor. And I want to assure you that the morphology is also not the textbook most classic example of the morphology. So I'm impressed that the author thought to do these stains and come up with that diagnosis. But these are much smaller and more solid than the classic examples. Okay. With that, unless any of our presenters or Dr. Hagemann has comments, I'm going to say thank you to everyone for participating. This has been great. Take care, everyone.
Thank you very much.
Thank you.
Thank you.
Thank you.